Yes, for the screening of relatives, first-degree relatives or so on, how often should it be done? Like, I have
Yeah,
an in-law who's,
sure.
so she's not
So,
my blood kin, but she had
yeah,
her father and her sister.
yeah.
One sister both died of it, and she was checked once by MRI. It was fine. So I've asked, well, have you done it again, or do you have plans? And I get no answer. But
Yeah,
what
there's a
should
lot
be
of
done?
that was actually a big topic of discussion at our last consensus about, because there is a lot of variation about what should be done that in part, conveys people's philosophical notions of, what it means to screen a otherwise healthy population. The risks associated with any intervention are a magnitude higher because you're taking an otherwise healthy person and God forbid you have a complication from your intervention. That's less acceptable than if you were doing something for diagnostic purposes. So our clinical workhorses today remain MRI and endoscopic ultrasound, and between those two, different centers do different strategies. In general, I think the consensus is lying between an annual evaluation alternating between the two. My German colleagues like to do MRI every year with an EUS every 3 years. Again, there's no science behind this. It's just kind of imbuing their philosophy of, the notion of invasiveness versus non-invasiveness. The general trade-offs is that MRI technology has improved significantly, and I think we're going to continue to see in this field of radiomics, where you're taking pixelations of CTs and MRIs, better improvement of early detection. But in the meantime, the MRI technology is fairly good if the tumor is greater than a centimeter. But once you're looking for a smaller tumor, the sensitivity drops significantly. And so, but the upside is there's no radiation and it's non-invasive, so it's fairly well tolerated. So that's why some centers focus on an MRI-based approach. Other centers feel that if the goal is for early detection and you're really looking for that 5 millimeter tumor before there's neurovascular spread, you really need to be doing it using EUS, and they'll do annual EUS examinations. Our center alternates between EUS and MRI.
So somebody who's totally okay on MRI should still be having it done yearly?
Over the age of 50, meeting those criteria of having a first-degree family member plus a hereditary genetic mutation, or having more than 2 family members, specific. So I think one thing is, so it's important to know what your actual risks are. If you, for example, just have a BRCA2 mutation, while that does increase your risk up to about 10% in the absence of family history, it's controversial whether you should get screening. There was only about 75% consensus, whereas if you had a first-degree family member plus BRCA2, then there was over 90% consensus. So there's less controversy about screening those patients. Yes?
So there's been a rapid evolution of rapid MRI, rapid access for breast cancer. It's now emerging for liver cancer, 6-minute MR with contrast, 1/3 the cost, 1/4 the time. Is that something you're looking at for pancreatic cancer?
It's not something that we're particularly looking at, but I think if that can be applied and that can that would definitely remove some of the barriers. I think it's interesting in my own clinical practice when I follow these patients, I have more problems getting prior authorization on MRIs than I do with EUSs. I think I don't know exactly why that is the case. My suspicion is that when insurance companies develop prior authorization protocols, they look at well, we're spending X number of dollars on MRI, so let's build a prior authorization program for it, whereas EUS by volume is probably smaller. So surprisingly, I have no problems doing EUS for these patients, but I have a lot of problems doing MRIs. So if they can get cheaper and they can get faster and more tolerable and without compromising the sensitivity, again, the critical issue is, can the technology improve to really show that we're going to find smaller and smaller tumors? That was, I think, the one Achilles heel with the MRI. I think for those of us in the pancreas field, we all have our anecdotes of that isoechoic lesion, or that lesion that is clearly there but can't be seen by CT or an MR, but is obvious on EUS.
I have a simple question. So trying to feed these patients within 24 hours, acute pancreatitis, should we put an NG tube down because they have so much pain, they don't want to eat?
Yeah, so again, I think the idea, the point is to offer them to eat. You're not forcing them. You're not saying you've got to eat. This is part of the treatment plan. It's more that you don't want to say that if they start to feel hungry and they want to try to eat, then the idea is go ahead and let them try. Now, some of them will have pain, and some of them will say, gosh, I'm having nausea, I can't tolerate that. So obviously they're going to back off on their own. In those situations, then as they progress, then the corollary is to place an NG tube or to start talking about an enteral nutrition strategy earlier than later. I think we really do not want patients sitting NPO for 5 days anymore. The general trend is what we really need to be educating our hospitalists is that we need to be starting and talking about an enteral nutrition strategy from day one. And if they're not tolerating PO by day 2 or 3, then you want to be putting an NG and start doing trickle feeds because of the data saying that there is, with enteral nutrition and stimulation, that seems to improve the immune system and that seems to not hurt the patient but do fairly well. And you don't need an NJ tube. An NG is probably sufficient. The one thing you probably want to watch for is obviously secondary ileus, where if they do have that, you might want to check for residuals. But the general theme is the fear of NPO is probably less founded.
He answered it already.
Okay.
My question about getting an NG2 past a ligament of tricuspid surgery.
Yeah, I think that's gone by the wayside as well. The whole idea, we used to think NJ feeding because you want to bypass duodenal secretion, duodenal hormone stimulation of CCK. Many of these fall back anyways. There have been some studies that just did NG versus NJ and found no difference. So I think NG is just fine. Yes, Paul.
Walter, few of us have seen more than a few patients who were cured of pancreatic cancer. I think I can think of 2 in 40 years. Are there molecular features of those who have had prolonged cures, have real durable cures, or something that can identify them aside from the size of the cancer? Because the presumption is catch it when it's half a centimeter and you might have the cure, but is there more to it?
It's a good question. I know that people have been studying at long-term survivors to see if their somatic DNA of their tumor might change. I don't know the details of what they've learned. I have not heard of any specific observations that have said these patients who have survived have a specific mutation profile yet.
Walter, I have one quick question for you. You touched on the multitude, and there are even more than I was aware of the guidelines for pancreatic cyst management. So in your practice, which of those ring truest to you as far as if you had to go with one?
I generally still adhere to the revised Fukuoka criteria. So the revised the Sendai criteria were the original criteria that came out in 2006, and then they revised it in 2012. Admittedly, they're short on methodology. They did not do a systematic review. They did not finance a very exhaustive effort to do what the AGA did. I think, again, the AGA did a wonderful thing by paying money to get that done, and it was very informative, but it showed where we were and that we lacked a lot of evidence. I think the Fukuoka criteria are more conservative, but they're more patient-based. So I think the other aspect about how you think about pancreatic cysts is, are you looking at it from the lens as the patient's doctor and the advocate and helping them navigate what's certain and what's uncertain about the data? Or are you looking at this from the perspective of a public health policymaker or an insurance person who's trying to say, well, how do we use our limited resources? And I think when I read the AGA guidelines, I can't help but feel that some of those guidelines some of the statements that they made were really more based from a population-based, which is not wrong, but it doesn't really help Mrs. Smith, who's in your clinic, who's asking you, well, if I were your sister or your mother, what would you want me to do in the absence of data? And so in that sense, I like certain guidelines are more helpful to help you walk through that. So that's my answer. Thank you.